Another story, again, some good news. At a physician advisory committee, before we actually got started, the doctors were talking about, what's working and what should happen. And they decided among themselves that the standard of care in our community is that the result needs to be, accessible to the physician electronically in 3 minutes. Now, that wasn't me driving them. That was them talking among themselves about how they expect each other to operate.
So in the waning minutes, Tom has a question, and if I could have a closeout question.
Hi, this is Tom Fritz. Thank you all for being here. I have a question related to the regional extension centers as well. And as you know, especially in relationship to the previous docket program, which there's concerns that some of it might just emulate exactly what we did before. So I would be very curious to hear your opinions about maybe what were the lessons learned or things that we should try to avoid in terms of advice in both building the criteria for the regional extension centers, but also helping define what the criteria should be for participation in that. Whether or not you think that maybe even some of the existing HIEs, should be part of a regional extension center.
So to your last point first, I think that the model could vary. In some places there aren't HIEs, so to dictate it would be obviously you can't do it. But it seems to me that in places where there are well-organized HIEs, trying to bring those together with the extension centers could be a natural way to bring them together. But again, I don't know if there's any reason to dictate it, but they do need to speak to each other. And to the extent that you're implementing, there are workflow issues that are another layer of workflow. What you can get the EHR in place, but then all of a sudden you introduce interoperability, and that's a whole different world. And and someone needs to do that roll up the sleeves work of getting that workflow done. But back to your to the first part of your question about the lessons learned. Not to be overly critical, but I think that as we look back a little bit on the docket program, and I'm not an expert on it, but my understanding of it and from what I saw in the places that I've worked. It wasn't resourced well enough, first off, and related to that is it wasn't involved in the really hard part of the process, which was implementation, which was really boots on the ground, and I think that's what this is about. And the third part is not really having a real ability to tell a practice, and I'll put that in quotes, what are a concrete set of goals that you need to accomplish, and I think that's sort of is really an overriding problem here, that you can go in and try to optimize a practice, and I'll put that in quotes, but according to what? And and it feels trivial, but it really comes down to this issue of we're trying to implement you, we're trying to do some process improvement, we're trying to transform the way you practice in certain fundamental ways, and the response is, well, I deliver quality every single day. And you're going to tell me that I'm going to change my practice for what reason and according to what? And so every incentive they have is toward changing as little as possible, and you're thinking that that we need to transform this as much as possible to take the most advantage of having this kind of technology put into place and used as effectively as it could be. So it seems to me that really a recognition that this really is an engaged activity. It's not something that can be sort of light and someone coming and speaking to a group of 100 physicians at an IPA or a PHO, giving them a 150-page book on workflow change with a bunch of worksheets, and then saying, "Oh, I'll show up 3 weeks later, and you'll fill out all the worksheets, and then and then I'm going to step away during the implementation because I'm not allowed to do that, and I'm not allowed to help you with vendor selection, and then I'll come back later and see how you're doing." I think those were sort of a lot of the flaws as I saw them of the docket program that we really have to get over in this.
Just a couple of quick comments. I think they have to engender trust, and that might mean working with local medical societies, professional societies, and others, and coming together in a partnership around that. And they also have to be, as Mickey said, a full-service provider. They can't leave folks hanging. If they're going to start, they have to help them finish. And I think that'll go a long way to getting folks to buy into the support that might be out there.
Okay, just when you think you're winning, the rules change. So the good news is you only have June 15th is around the corner. The bad news is it's 2 weeks too late. So we have what we have, and $34 or $46 billion is a lot. There is one meaningful use criteria. 2011 is still 2011, and it's still $18,000 for that. what would you do to make it, to facilitate this process for small practices?
Well, I can share with you what we're doing at the ACP for our membership is providing them as much information as possible about the EHRs that they might be able to select, recognizing we don't have the specific criteria just yet to kind of tell them which of those EHRs can provide that service.
So actually my question was, what policy would you write? Because we don't have the luxury of the sure scripts in the private sector. We can do it incrementally. There just is one policy.
Yes, one policy would be mandatory quality reporting and public health reporting. So if you can get that, all the other stuff will come along the way.
Yeah, I'll go with mandatory quality reporting of some kind. I really want to highlight what HITSP is doing, though, in terms of trying to standardize and give us reusable components and modular components. I think we can at least start with a lower rung of the ladder and say, okay, we're picking out of these 14, we're picking 2.
Certainly the quality reporting and public health reporting make a lot of sense. Being able to actually utilize public health is a good example. We actually capture the data that needs to go to public health and route it to public health. But then when we checked with the people at the state that wrote the law that said the physician has to pick up the phone and call, they weren't willing to say unless you have it electronically. So having policies that say if there's a certified health information exchange, then you may or you can or you shall do thus and such with it, so that we don't just build it and not have organizations come up and use it, including the various organizations that all of our customers report to. We'd love to be able to consolidate that reporting, do it electronically, and just make it a function of the workflow, not something that they have to do separately.
Comment I have, I understand the call for quality reporting, but we've all heard that even those who have implemented over years can't do it currently, so I'm a little concerned about making that sort of the meaningful use criteria for 2011. However, I understand the reasons that's been chosen. I think there might be something a little different, perhaps medication reconciliation.
Well, I would like to thank the panel again for a terrific presentation. Mr. Chair, I'll turn the meeting back to you. Thanks.
Thank you, Paul. Paul Tang is the Chief Medical Information Officer of the Palo Alto Medical Foundation and a member of the NEHIC board. And I, too, would really like to thank our panelists, Michael Barr, Will Ross, Bob Steffel, and Mickey Tripathi, for outstanding presentations and conversation now. We're not going to take a break. We are going to move into the next panel. So if you'd like to stand and stretch while we introduce the next panel. And I'm pleased that another of our board members, Steve Finley from the Consumers Union, will assemble and then introduce our next panel, which is Consumer Demand Pull for EHR Adoptions. Is it possible?
That's okay. Thanks, John. While the panel's coming up, I'll say a few words. So in contrast to the last panel, I think the consumer community thinks all this stuff is going to work out just absolutely wonderfully. And it's all going to be very easy. Not. We have a sunny disposition towards all of this. Thanks, Laura and John, for inviting me to assemble this panel, and thank you especially to the panelists, Deven, Christine, and Dave, for coming, and Jody. Jody's coming forward. She's here. She needed her nameplate. Their bio sketches are in your book, but really quickly. Deven is now the Health Privacy Meister at the Center for Democracy and Technology. She knows everything there is to know about privacy stuff. right down in the weeds. She's also on the HIT Policy Committee. Christine is the Vice President at the National Partnership for Women and Families, which is the home to the Consumer Partnership on e-Health, which many of you may be familiar with. She was at EHOT before joining NPWF. She's also on the HIT Policy Committee. Jody is a doc and practicing internist from Oregon. She was the HIT coordinator for Oregon from 2006 to 2008 and recently worked with CCHIT on their upcoming PHR certification. She's well-grounded in all this. Dave may be known to most of you in this room as ePatient Dave rather than Dave deBronkart, his real name. Dave works at a software firm in Boston, called TimeTrade. But he's recently become widely known for his blogs and reports on his run-in with kidney cancer and his scrutiny, very close and meticulous scrutiny of his own medical records. In February, Dave joined with one of his docs, Danny Sands, to establish the Society for Participatory Medicine. So each of the panelists is going to take about 5 to 7 minutes for remarks, and then we'll do some Q&A. I'll have some questions and then open it up to you all. In order of, and please state your name before you speak. We've gotten some messages apparently. Laura said that people don't know who's talking, so mention your name first. Christine, you want to start?
Sure. Good morning, barely. This is Christine Bechtel with the National Partnership for Women and Families, and thanks very much for the invitation to be here today. I have no slides, but I do have some paper that I'll, why don't I actually sort of go ahead and pass out? Or maybe we have one of the staff, because I have 2 separate pieces, so we can go the other way. I know, right? It's very exciting. I'm starting a revolution. So I wanted to focus my comments this morning on consumer engagement, and I want to talk about it in 2 respects. Obviously, you see the demand pull for EHR adoption, and I want to get there, I think, in some of the panel discussion. But I'd like to talk about consumer engagement really at two levels. One is how to do it at the policy level, and the other is how to do it more at the systems level in clinician practices and hospitals across the country through information technology. But I'll start with a brief overview of, oh, John, you're saying, no, it's not. Okay. I once dumped mine in a mud puddle. It survived, except the T key. So if you can live without the T key, you're good.
For those on the call, I just poured coffee on my PDA.
Yeah. A large puddle of it. So the National Partnership's been around for about 35 years. We started our work in the area of what we call work, family, and workplace fairness. So our early years were really focused on eliminating discrimination in the workplace. We were part of the first lawsuit that made sexual harassment illegal. Over time, we realized that we needed to change the conversation that was happening around how women can, in particular, meet the demands of caring for their family and succeeding in the workplace. And so we wrote something that most of you have heard of called the Family and Medical Leave Act. And from that experience, we led the FMLA Coalition for about 9 years as a very diverse group, broad tent of stakeholders who came together for various reasons, often many who weren't on the same sides of issues, not that any of us would know about that. But we, from that experience, began to understand sort of the real impact that that women face in the healthcare arena, in particular through their caregiving and other duties. We led the Patients' Bill of Rights Coalition, actually, as a result of the work that we did with the physicians and the trial lawyers under FMLA. And through that, really got a great sort of view into what we see as the 3 kind of key components of healthcare for women and families: cost, quality, and coverage. I think there are a lot of consumer groups that many of you know that focus on access and coverage in particular, and that's true for us as well. But we also focus and have developed a pretty deep expertise around delivery system reform. And the reason that we did that, and the intersection of our healthcare work with our work family and work fairness work, really comes into play around caregiving in particular. And so today, as we look at issues that women and families face, we see particularly boomer women who are still having some caregiving responsibilities for their own children. At the same time, they're having to care for their aging parents who are living longer with more and more complex chronic conditions. At the same time, they're coming into contact with the healthcare system as they develop their own chronic conditions and finding it in a state of disarray.